Hi, everyone. Thank you for joining us for our weekly webinar on preventing and managing COVID-19 in the workplace. This is our 44th consecutive week. We welcome you once again if you're a regular attendee, and if not, welcome for joining us for the first time. We follow a routine format, which you'll become familiar with if you're going to be joining us on consecutive weeks moving forward. This is Karen O'Hara. I'm the Director of Marketing and Communications at WorkCare and the moderator for today's session. The session is being recorded and will be posted on our YouTube channel. All of the questions will be answered in writing and posted on our website, workcare.com. We always take as many questions as we can in the time allowed, and those we don't get a chance to answer, we answer those in writing as well. Our speaker today and every week is Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and Associate Medical Director for on-site clinical operations. He's also our lead clinician for WorkCare's COVID-19 response. And now I'll turn it over to him. Thanks again for joining us.
Excellent. Thank you, Karen, and thanks everyone again for joining us for our 44th consecutive session. Today we're going to pack it full for you all, and we're going to move quickly here so we can maximize our time for questions. Today we're going to hit on a number of topics, and as we move forward, we'll make sure that we double down on some topics that you've already become familiar with because they're becoming more and more important in managing our workforce in regards to the outlook of COVID for 2021. So let's go ahead and jump into the program here. We know the format. You all probably are familiar. Hopefully you're familiar for joining us again. Clinical update comes first, followed by microbiology and some pathology. We'll keep it simple in that bucket today. And we'll move into our epidemiology, looking macroscopically at how we're doing in the US on a number of metrics. Then we'll jump into the preventative information that we need to be aware of, the trends, macro, both globally and in the US, more importantly. Then finally, what are the strategies that we need to be aware of, cognizant of as we look at 2021 and what we're going to be facing from a strategic standpoint year long. So without further ado, today we're going to be talking about, for our clinical update, an update to presentations clinically of individuals affected by COVID-19, specifically looking at an update on hospitalized patients versus non-hospitalized patients. And as you can probably recall, the most common symptom for both camps are a cough in regards to effect of COVID-19, followed by fever, measured fever, and subjective fever, combined to consider any fever. Then those body aches, myalgia, chills, the headaches, and the shortness of breath, followed shortly by the hospitalized, experienced more so by the hospitalized patients than the non-hospitalized patients. So when we talk about updating for nuance in regards to presentation clinically of individuals that have been infected with COVID-19, we can see that there's not much change from when we first started dealing with COVID-19 and understanding how people were presenting. And that's important to re-understand again, because we know that there are different strains out there that have made the news, the UK variant, the South African variant, and we want to reassure our workforce that yes, we're seeing new strains come out, but no, we're not seeing new health outcomes and effects from a hospitalized and non-hospitalized standpoint in terms of clinical impact. And as we look at then some metrics to further understand how individuals are presenting in the US in particular, we want to look at a comparison of overall symptomatology that's associated with flu-like symptoms, which is in this chart here depicted as ILI, so that's influenza-like illness, measured by two different data sets in the US, the NSSP and the ILI net. And then we'll look at that compared to the COVID-like symptoms, CLI. Why are we looking at this data? We want to see if we're understanding accurately clinical presentation for hospitalized individuals in the emergency department and for outpatient in the US year over year, comparing 2019 with 2020. Okay. And so at the bottom of this chart, what we're seeing is a week by week analysis or breakdown reporting of those metrics of people showing up to the hospital with these like symptoms, either COVID or influenza like. And what we see is kind of interesting, right? We see a spike if we look at the weeks 48, 46, 48 through 50 and 52 weeks in 2019, right? Tail end of that year when we start the influenza season, and we see this presentation spike of influenza like symptoms, right? And so as we look at both indicators, both data sets, we can see mirroring of that data for sure. And we know that COVID like symptoms started in the tail end of 2019 in the US as they were imported from overseas, if you would. And we can see how that has grown over time in terms of reporting. So if we look at that same time period in 2020, we can see that we have a spike of COVID like illness presenting, right, as labeled by the department, emergency departments and hospitals, and not as much in regards to the influenza like illness, right? And so we want to continue to look at this and kind of break it down from a diagnosis standpoint as we move forward, because we want to, again, when we're talking about articulating burden of illness, get a ever more accurate picture of where we're at in the US, how we're faring, and we'll be using the positivity rates that we see with testing these individuals to kind of undergird and characterize these numbers and these presentations. If we look at the influenza season for specifically influenza-like illness in the US, same time period from tail end of 2019, fast forwarding to 2020, throughout 2020, and we break this down now on an age-based process, we can see that the presentation classically for flu-like symptoms, again, spiked in the tail end of 19, and we're not seeing that spike in the tail end, similar time period, weeks-wise in 2020. So frankly, how we're labeling these presentations has changed, right? And so does that correlate to the burden of illness? And we've talked about excess illness, excess death rates from state to state, macroscopically in the US. And we'll look at these metrics to try to continue to understand how we are presenting clinically in the US. Again, we want to make sure that with our workforce management, that we are understanding the communications to the workforce in terms of what their symptoms are, right? And how their symptoms may be related to COVID versus flu, and appropriately getting these people the right care at the right time. And certainly all of our processes that we've instituted at WorkCare are geared towards demarcating as accurate as possible and as quickly as possible these presentations so that we're not overtreating and we're not don't have an undue burden of cost associated with evaluation of these individuals in the various settings of EDs and outpatient centers, right? So therein lies the nugget for return on investment and truly understanding this and having a process to articulate the differentiation and make sure that we are controlling costs. Because as we'll talk about, we're in this for the long haul throughout 2021. If we break this data down now, again, for hospitalized patients specifically that are being reported per 100,000 in the population, and if we look at then where we are from an age-based standpoint, who's presenting to hospitals by age group from March 1st, 2020 to January 2nd, 2021, we can see by far and away the age group most affected presenting to the hospitals is 65 and older. And again, this is attributed, this is CDC data and attributed to impact from COVID-19. And so we'll continue to look at, is there any change in proportionality from this aspect of impact from COVID-19? So now let's get into some pathology. I told you we're going to keep it super simple today. We got a one-pager, believe it or not, for our pathology update, but we're going to walk through it a little gradually here because we want you to understand comprehensively what happens when someone is infected with SARS-CoV-2, okay? You might get this question specifically. Hopefully that question bounces to us as clinical experts and advisors for you, but we want you to understand it from a simplicity of once you're infected, what creates the viral count uptick in someone that causes them to be infectious to other? How does that actually happen? So we, again, will keep it high level, won't break it down to its minutia, but we want you to understand this pathological process. So we are all familiar at this point with the spike proteins that we are concerned about from a mutation standpoint and being able to affect individuals differently as the virus mutates, right? And so we see this depiction here at the top. I'm going to do something I don't do as often. I'm going to bring out my laser pointer. All right. So hopefully everyone can see that on their screen. And we see these spike proteins that allows the virus to enter our cells. That is what, again, is mutating over time, amongst other point mutations we've talked about in this presentation. The spike protein allows the virus to bind to receptors called ACE2 receptors and enter the cell. And this process of entry happens through this enzyme here. We won't talk about that. I won't bore you with the long name of it, but this TMPRSS enzyme breaks down the components of the surface of SARS-CoV-2 and allows the viral particles to actually fuse the viral membrane with the host cell membrane. And this fusion then allows the genome of the virus to enter our cells. And it's a quite elaborate but eloquent process that the virus has, as other viruses do, to cause our cells and our infrastructure of our cells to replicate the genome of the virus itself. So our body recognizes, oh, this is genetic material that should be replicated, and our cells go about doing so. And that is the core process by which the viral count goes up in our system, all right? And so because of that, the virus then is reassembled and released from our cells to cause additional infection, right? And when we talk about then shedding of the viral particles, we're talking about this entry and amplification process that allows people to have high viral counts. When we're doing PCR, that's how we're detecting genetic material from this high viral count. And when others sneeze, cough, have excrement from their respiratory system, that is what causes these viral particles in our sputum, in our droplets, is what causes others to become infected. All right. So that's a simple breakdown of the pathological process. I think that's the first time we've really talked about the process at this level. And then we want to comment quickly on some of the cytokines, or the process by which we develop the immune response to SARS-CoV-2. And we look at angiotensin 2, which is important for our vascular system. And this gets activated by the virus, and it leads to pro-inflammation. Cytokines also lead to pro-inflammation. They're basically ways in which the cells talk to each other, chemicals that allow the cells to talk to each other. And the coagulation factors. We talked about how the virus is able to activate different coagulation pathways, and that leads to the increase in potential for stroke, the erectile dysfunction effects, as well as other microvascular effects, right? And so it all is put together here simplistically for you to understand and communicate again when prompted how these things transpire. Again, the messaging to our employees is, this is not hocus pocus, right? There's still some that believe SARS-CoV-2 is not really, is not real, right? And certainly we want to be able to break it down to them and help them understand accurately what the picture is. So let's jump into now our epidemiology as I turn my laser pointer off and we start to look at how we're doing here in the US from a perspective of impact of SARS-CoV-2 2 weeks ago, right? At 19 million and 54.2 per 100,000 in the US, climbed last week to 20 million, almost 21 million, and 64.5 per 100,000 in terms of overall at 7-day rolling average in the US. And then finally jumping well over 2.2 million this week as of today, and 74.8 per 100,000. Obviously, we're still feeling this dramatic increase in incidence and prevalence. So we want to be prepared to deal with this in the workforce. If we talk about deaths, we see at that 19 million mark 2 weeks ago, we were at 0.7 per 100,000, 0.8 last week per 100,000, and unfortunately this week we've hit 1. Right, so 1 of 100,000 people die from COVID-19, right? And so we're going to see this continue to climb, very likely, right, in the weeks to come at 1.1, 1.2 deaths per 100,000, and we'll see where we hopefully peak in the springtime and start to decline here, as we have anticipated with models pointing out the overlap of flu season and COVID seasonality to the illness itself, spread of illness itself. If we take a step back then and look macroscopically at how we're doing, how we're faring comparatively to some of our neighbors, again, overall, new daily confirmed cases in the US on a 7-day rolling average, obviously well over 200,000, approaching 300,000. And if we look at then cases per million, we are still leading. We're still leading most. United Kingdom continuing to lead us in regards to per million cases, and we'll see as they have accelerated their vaccination process, which metrics we will look at shortly, how these numbers start to decline as we get to the general population vaccinations moving forward. If we look at deaths now, again, we're less impacted than the United Kingdom on a per million basis, as well as comparatively to Germany, but still obviously hitting that mark of 10 per million in this metric on a 7-day rolling average. Then we talk about the test positivity rate, right? And we're looking at the positivity rate from last week, where we were with Mexico leading, and the United States not too far behind, but well behind South Africa, Colombia, Germany, and United Kingdom, as well as Italy. If we look at that total tests for this week, where we stand, 1.2 million was where we were hovering for a while. We spiked over 1.8, and now we're coming back down again. We'll watch this just to understand, again, the success in the US of performing these tests. From a positivity rate update as of today, we're still climbing dramatically. And we've seen this climb since fall of last year in terms of overall positivity rate. Germany's ahead of us, but that's about it, right? And so again, we know that our overall accuracy is underestimating the positivity rate here in the US. And again, we'll probably next week show this in the serological updates that have occurred in the US broadly. And we'll look at, on a rolling basis here, how we're doing from a vaccination process. And we're seeing some positive movement proportionally here for distributed doses versus administered doses. So right now, as of today, 29 million distributed doses of the vaccine in the US, right? If we look at then the number of people that have received their first dose, we're at the 10 million mark, right? And so last week when we presented this, we had few states that had over 2,000. Obviously, at this point, most states, if not almost all states, probably this week will have over 2,000 plus initiating their vaccinations per 100,000. When we look at this number, then taking a step back macroscopically, looking at how we're doing comparatively to other nations in our vaccination efforts, we are at the top. That's obviously a good indication here of how we're doing from a totality standpoint of administered doses, right? We're over 600,000. If we look at, and this is a 7-day rolling average, right? So this is 7-day rolling average of dose administration, compared to China that had their vaccines far before us approved. United Kingdom approved shortly before we did the Pfizer vaccine initially. Then we can see some other key nations here, UAE with their use of the Chinese vaccine. Italy, Russia, Germany has two approved. Russia has two approved, and you can see their vaccination progress there. So we'll continue to watch this metric. We'll see this metric also per 100,000. If we look at this number, we can see the UAE leads on a per capita standpoint on 100 people basis, okay, persons basis. United Kingdom is ahead of us in regards to this metric, and then we're right there in third place, so to speak, right? So we have some acceleration that hopefully we'll see in regards to how we're logistically getting the vaccine out there, and then we'll start to glean inferences from participation standpoint, utilizing this data and some additional data that we'll look at for are our workforce prepared to take the vaccine once available, whether they're in the 1B category or additional categories from a prioritization standpoint. And that'll be important to understand. And we'll look at also those that have required the vaccine for a means of employment. So from a topic standpoint, we want to jump into prevention, some of the trends that we need to look at so that we are prepared for 2021. The first thing we'll look at is vaccine access. As you know, vaccine access is a state-by-state determination, and it's predicated on that state health department's desire to partner with large hospitals, partner with healthcare organizations, as well as companies potentially in certain locales. And if we look at then some areas where, in this case, singling out UC Health in California, they have made it simple to their network to get vaccines and send out notifications if you're a part of the network and have registered on two fronts. So if you registered, you'll receive automatic, if you're the general public, you'll receive automatic updates of when it's your turn to receive your vaccine through UC Health. And you can register online and do this type of process pretty straightforward. And we see this play out from different states in regards to access to the vaccine, not just for the first responders, but also in the frontline workers, but also for the general public. And so that'll be important in terms of how your workforce will access administration of the vaccine. And we're seeing this for the most part play out and be centered on the public health departments distributing directly to large healthcare organizations, not so much making the employer the epicenter of distribution for certain workforces. Now, certainly the conversations are ongoing in terms of ultimate logistics of how the vaccine will be distributed, and we'll see how this plays out as the weeks progress here. The thing we want to talk about next is really asymptomatic spread, right? What is the impact of asymptomatic spread at this point? Because this will be important and germane to how what we have in place in the workplace for prevention now and what we'll need moving forward throughout 2021. So if we look at some recent publications, this was in November of last year around kids in particular and whether or not kids can be a vector, because there's been some on both sides saying kids are not as infectious potentially as adults, and kids, even though they may be asymptomatic, can't transmit because their viral load is too low. So let's hit that straight on into this article that looked specifically at 382 children. This study wanted to examine, is there a difference in how children of different age groups presented? And is there a difference in how their viral load manifested? And if we look at those individuals from age 6 to 13, they more frequently presented asymptomatically compared to their younger and older cohort. They had those who frequently presented with symptoms were in the younger camp, right, 29% versus 39% in the 6 to 13 age range. All right, compared to their older cohort, it was 29% as well that presented with symptoms. So we know that particularly in this 6 to 13 years of age, more likely than their counterparts, younger or older, to be asymptomatic at that 40% mark there. If we look at quickly here, comparing children age, again, 6 to 13, they are more frequently reported, compared to this group, other children more frequently reported influenza-like symptoms, okay? Gastrointestinal symptoms as well were reported amongst this group. The most important thing we want to take away from this study, though, as we talk about prolonged illness in the cohort outside of that 6 to 13 years of age, existed, as well as a duration of, so with kids, the duration of illness and ability to transmit the virus outside of that range was 7 days compared to 4 days if they were in that asymptomatic 6 to 13 year age. If we, and then what we also want to take away from this is that the viral load from a nasopharyngeal swab of these cohorts were similar, basically the same, right? So whether or not they presented with these symptoms, the influenza-like symptoms in the younger and older group versus the asymptomatic group that's 6 to 13 years of age, they had the same amount of viral load in their nasal passages. And so what does that mean? That means, yes, children can spread COVID-19. So don't take it easy in terms of recommendations to families and workers, the recommendation to wear masks on those children, because again, some have proceeded down a pathway of less concern from a children to adult transmission. And those children 16 to 13 may be more likely to be asymptomatic. So again, precaution around how those children are being protected from a exposure standpoint, as well as from a transmission standpoint, mask wearing, etc. And then the viral load, again, comparative for those who are asymptomatic versus symptomatic. So again, we have to have strategies in place to address not just in the pediatric population, but also from the adult population. So let's look into that and dive into that trend here, updating around COVID transmissions for people with and without symptoms. And we're talking the adult population now. So if we look at this particular study that was published recently, we see that the goal of this study and design was to examine those individuals who had a potential transmission and what rate, as we modeled it out in this study, of transmission occurred for pre-symptomatic people, from people who never became symptomatic, and those who were symptomatic throughout the period in which they were able to transmit the virus itself. And what we understand from this study is that the presumption is incubation period of a median of 5 days was used, and the infectious period was a 10-day average, right? And peak infection occurred between 3 and 7 days. So these were the set points that were identified to model out what accuracy we can nail down in terms of transmissions in the U.S. From people with and without, from people, excuse me, without symptoms occurring on a rolling basis. So if we look at the results then, and what this study revealed for us is that 59% of transmissions came from asymptomatic transmissions, right? 35% coming from pre-symptomatic individuals and 24% from individuals who never developed symptoms whatsoever, right? And so again, if we're looking at these assumptions with the broad range of assumptions, at least 50% of new SARS-CoV-2 infections are occurring or have originated from individuals without symptoms. Right. And so again, this is very important for us when we're talking about preventative strategy throughout 2021 with the new strains that have surfaced that have pointed to being slightly more infectious, again, not causing more severe disease, but being slightly more infectious than previous strains. Then we need to pay attention to, do we have the right strategy in place, not just to prevent workplace transmissions, but also to minimize absenteeism from a transmission and occurrence of positivity in the workplace, coupled with a rapid return to work identification pathway as well. So that's what we'll get into in terms of our workforce strategy here. If we look at a prospect of where we sit for the U.S. globally as well with regard to reaching herd immunity. WHO lead scientists recently put out that, look, we're not going to reach herd immunity likely in 2021. And we spoke to this in this venue not too long ago in terms of timeline of herd immunity being at earliest the fall of this year, right? And that magic number being 60% of the population, 196 million individuals. What likely is playing out now as we look back to the infectiousness of SARS-CoV-2 and the number that we need to actually hit for herd immunity, it's closer to that 70 to potentially 80% of the US population, right? So we're well over 200 million people that need to be vaccinated and or have received natural immunity from an infection of SARS-CoV-2. And so what does that mean? That pushes us out well beyond 2021 into 2022 to reach that herd immunity to the point where we're not requiring the things that are in place to help keep us safe from a transmission standpoint. I know that's a sobering reality, right? But all of the data is pointing to that reality in regards to how we're going to be dealing with SARS-CoV-2 throughout 2021. So with that, the reality check is straightforward. Is your business prepared for COVID for all of 2021, right? And what are the considerations that we need to have in the forefront here? Obviously, we have in place, most likely at this point, some type of screening process and ways to deal with people who are at risk because of an exposure and getting them the right care. And hopefully that involves testing, both locally, maybe on site, and having a nice return to work program. However, we know a large proportion of our employers are still doing this internally, right? And a large proportion of our employers don't have a surveillance program in place. So what does that mean? That means we need to look at one, first and foremost, can we prevent people from showing up to work that are asymptomatic, that may transmit and present a problem, obviously, for workplace transmission? That's the surveillance piece. And then we need to talk about the real and opportunity costs for doing this type of process internally versus with the partner externalizing the COVID-19 management from end to end. And then finally, what is the worker participation look like throughout 2021 when we talk about COVID fatigue, and what does our messaging need to be so that we can continue to protect our workers as much as possible and as well as best practices moving forward. And again, in the context of we need to maximize return on investment for our efforts as well as minimize absenteeism. So we talk about tertiary prevention being in place, having a process for dealing with people, with workers that become symptomatic or are tested positive for SARS-CoV-2, right? And what is the return to work process? If that return to work process doesn't rapidly identify the best time point to get people back and use every opportunity to shorten the quarantine period at this point, then we know up front throughout this year, we're going to be keeping people off work and experiencing higher absenteeism than we necessarily need to hit a balance of protection for workplace transmissions. If we're looking at secondary prevention now, capturing those individuals with early symptomatology, hopefully this is the most robust piece of your preventative strategy in regards to screening out individuals who become symptomatic and keeping them home safe, and hopefully putting them into a return to work process that gets them back as soon as possible. We'll talk more about this in regards to how we can double down on a secondary preventative strategy utilizing immunology as we move forward throughout the vaccination process. And then primary prevention, we believe, is where the real return on investment is going to be with regard to doing surveillance testing throughout the 2021 time period, right? So essentially, the fewer people we have into the overall process of secondary and tertiary prevention, the lower our costs will be, right? And this goes back to the whole adage that the prevention is an ounce of prevention is worth a pound of treatment, right? And so we want to make sure that we're focusing in on our surveillance piece as a robust component to our preventative strategy. And we're, yes, talking about pool testing, right? Pool testing is something we've mentioned time over again in this setting, and we want to refresh your realization that pool testing is going to be in place throughout 2021 for many organizations. And what that looks like in terms of a strategic standpoint is really doubling down on the opportunity to keep the people who are asymptomatic that can cause workplace transmission and can cause at-home transmission, right, and cause higher absenteeism from that perspective, safely quarantined. And the process of pool testing, again, to quickly refresh your memory here, is taking samples from workers that are asymptomatic and don't have a history of exposure and testing them across the board, right? And we know we have strategies that we can partner on to identify higher risk areas or more critical business operations that need a higher level of protectionism from a strategic standpoint. And what we do with those samples then is pool them together, test them all at once, and that dramatically bends the cost curve of doing surveillance testing in the workplace. So WorkCare is prepared to move forward with pool testing with our partners currently, and we can talk more about what that looks like in detail in weeks to come here. So we want to help you understand that pool testing gives you the advantage of screening individuals at this point in time. Again, identifying with a lower cost perspective the individuals that are asymptomatic and positive, as well as obviously, hopefully, capturing those individuals who may develop symptoms that didn't get caught with any filters that you have in place from a screening standpoint, as well as then driving home that this is also a diagnostic test for individuals as well, all in one swoop, right? So it's not retesting individuals, it's not requiring any complexity on the back end other than we can, within a 24 to 48 hour period, provide information to you on the fly of who needs to quarantine safely and who can still be in the pool of workers that are screening and can show up to work with the processes in place. And if you don't have data that is simplified and distilled, as we have been doing for some of our, and this is a representation of that for our employers, then you're missing out on an opportunity to prevent workplace exposure, we believe. So this is an example of going end to end from doing a daily screen in this case of symptomatology on a digital platform that we developed, where 13,211 workers for this one company was done on January 12th, right? And out of that 13,000, 13,140 were cleared to go to work. 71 remained at home. From that 71, we created automatically for them in their HR database, 51 new cases in their HR, right? And coupling that with our clinical stratification, that our clinical staff reach out and personally touch these individuals, we were able to clear for work that day within an SLA of about an hour, 6 individuals. And we got them back to work because their symptoms weren't consistent and high risk or medium risk for COVID-19. And coupled with previous non-cleared individuals, the 54, we put into their return to work program 20 new individuals, right? And so again, we're able to track at a very high level of detail these individuals and manage the process in partnership with your organization so that we off-shoulder the burden of trying to manage this for your organization nationwide, internally, and again, increase the opportunity for capturing value for your programs, your processes throughout the entire year. So that's the name of the game, right? We want the easy button for you. We've been doing the easy button. And since we're talking about vaccinations in the weeks to come, we're going to talk about, again, a new set of data that we'll be adding to this type of process flow so that we can identify positive asymptomatics with the screening pool testing. And we'll show what that looks like again in the weeks to come as we ramp up that process. So we covered a lot today. It's been fun to talk about where we're going to be dealing, how we're going to be dealing with 2021, and some of the strategies we need to have in the forefront of our brains here. So we'll stop there. We'll open up the questions, and thank you so much.
Thank you, Dr. Harris. I just Neglected to mention earlier that we are going to be posting a frequently asked questions on the vaccine, probably at the end of the day today or by tomorrow at the latest. So be sure to check that out. It'll be on our website. We'll jump right into questions because we're running short on time. I've heard the 6-foot rule, masks, ventilation, etc., are no match for the new strain of the virus. Should we be moving back to separated or siloed work groups?
Sure. So in terms of ventilation, in terms of social distancing, that all is still prudent. And at this point in time, there is no recommendation to expand that distance. However, that is in the context of you're still wearing a face covering. If you're still wearing a face covering and requiring the face covering, it's sufficient to, even with the new virus mutations, protect workers with the precautions of the distancing at 6 feet, as well as trying to increase ventilation. So at this point in time, no substantial changes if you have in place all the precautions that are currently best practice.
Okay, we have a number of questions about immunity. One of them is, why should I get a vaccine if I've had COVID?
Sure. So if you've already recovered from COVID and you have natural immunity, as far as we know, that natural immunity remains applicable to prevent future infection for about 90 days, right? And it could be a little longer than that, as we've spoken about in this venue previously. But that 90-day mark is when we draw the demarcate when someone has a new exposure and their requirement to quarantine and remain at home. So what we need to consider is still getting the vaccine if you've recovered from COVID-19 to extend your system's ability to recognize and fight off any new exposures of COVID-19. And that's what is prudent still for those who have recovered.
What would happen if you're asymptomatic, don't realize you're sick, and you get vaccinated while you're infected?
Sure. So if you are infected, asymptomatic, you get vaccinated, the end game will still be that you develop, potentially in that case, both natural and acquired immunity. Your body basically recognizes it the same. The immune cells recognize the both native infection as well as the introduction of the viral particles, the spike protein, for the acquired immunity from the vaccine. And that's going to result in you still being protected at the end of the day.
Okay, a couple questions. We can't get to them all today, unfortunately, because we're short on time, but there's a couple questions about pool testing. For pool samples, how large should the pool cohort be?
Sure, it depends on your population size. There is a maximum to the pool size based upon the assays that we're using. In this case, the maximum is around 20 to 24 individuals in any given pool. And again, that's predicated on the sensitivity of that particular laboratory's capability to detect viral components in a certain aliquot of sample. So at the end of the day, though, we recommend around 20 to 24 people per pool. It can be lower for sure. It can be as few as 2, but to bend the cost curve as much as possible, get the number around $20 a test. That's the number we're recommending.
A couple of questions about the demographics you always present at the beginning. What percentage of the world population has been infected? And what percent do we expect or speculate will have been infected by the time the pandemic is actually declared to be over?
Well, we know that the number, in terms of when it's going to be over, is a component of both, natural immunity and acquired immunity. And again, when we talk about that number, we're talking about potentially 80 million people, 80% of the world population needing to have immunity to SARS-CoV-2. And in terms of the global percentage of individuals that have been infected, I haven't gotten an updated number for today, but I can report that in our Q&A so that I give you an accurate number.
Okay, yeah, we got another question about protection for 8+ months post-infection on B memory cells, but I think we're going to have to address that possibly in the next webinar. We could talk a little bit more about the protections that the vaccines afford. And those are also answered in the FAQ that we're going to be posting. But unfortunately, we're out of time for today. So those of you who didn't get your questions answered, please check back on our website for the Q&A that we'll be posting before the end of the week. And also reminding you that we do have the recording of the webinar posted on our YouTube channel. Thanks again for joining us this week. We're shooting for number 45. Same time, same place next week. So thanks to you all, and thank you, Dr. Harris, as always, for your expertise.
Excellent. Thank you, everyone, for attending today, and we'll see you same time, same place. Take care. Stay safe. God bless.